people will join us throughout. I'm Valentina Grossi, Technical Officer at the WHO Regional Office for Europe, and I have the honor to moderate today's event, which is an informal discussion about a specific area of WashFit. And today we will talk about water quality management in healthcare facilities, a topic that I'm particularly excited about as we often receive so many questions and we see high need in countries. We will hear very interesting presentations, so stay tuned. And I'm sure you look forward most to the discussion towards the end. But I pass the floor to Arabella Hayter from WHO headquarters, the mastermind behind WashFit, to give us more information on this series.
Super. Thanks very much, Valentina. Hello, everybody, and welcome to this session. We're really excited to have you with us. And for those of you who are watching this afterwards, where it's going to be uploaded to YouTube, thank you for joining us as well. I'm just going to highlight very quickly and give you a taste of what's to come for the rest of this series. So as Valentina said, this is our first session of the 2026 WashFit Meetup series. We so far have 3 more sessions planned for this year, but there may be additional sessions coming. And if there's a topic that you're particularly interested to learn more about and have a session on, then please do get in touch with us. We'll put our contact details in the chat box so you can share any thoughts. So in May, we're going to have a session looking at plumbing for health, looking at some considerations specifically for safe and sustainable plumbing in higher income settings, giving a taster of some new standards and plumbing guidance coming, which WHO and UNICEF will be working on this year to be launched next year, and hear from some country experience from the Philippines. In July, we'll be having a session on healthcare waste management, a topic that time and time again we get requests for more guidance on, hearing some country experiences of recent work to reduce mercury exposure, so in Montenegro, Albania, and India. And also give you a taster of a new, very exciting WHO Academy course on healthcare waste management. And we'll be hearing from the International Solid Waste Association in that session. The last one that's planned is on emergencies and looking at how you can apply WashFit in emergency settings. And we'll hear some work that's ongoing, the integration of IPCAF and WashFit specifically in Democratic Republic of Congo. The idea very quickly with these meetup series is to be an informal sort of drop-in session where you can learn more about WashFit, some really pertinent issues, technical issues related to the implementation of WashFit, but also to ask questions and really, get some technical expertise from all the experts and country speakers that we're going to have. So with that, I'll pass back to Valentina, who's kindly going to moderate this session, and she'll introduce the speakers that we have today. So thank you very much, everyone.
Thank you, Arabella. Then it is my honor to introduce Rory Mckeown, my colleague working with us at WHO Regional Office for Europe, but also at headquarters, and he will give us a presentation to introduce the subject on the water safety in healthcare facilities. Rory, the floor is yours.
Okay, thank you so much, Valentina. Hello, everyone, and thank you very much for your attention. So what I am just going to briefly explore up front, just to provide some framing, is to take a look at why safe water in healthcare facilities really underpins quality care and how, applying simplified risk-based principles can help facilities to strengthen water safety, particularly in settings that will be lower resource and include emergency contexts as well. So safe water, as I'm sure you're all aware, in healthcare facilities really is fundamental to protecting vulnerable patients, preventing infections, enabling safe clinical care, and ensuring that treatments that are life-saving can be delivered without causing any harm. So when we delve a bit more into that statement, it really becomes clear why safe water plays this central role in quality of care. It protects patients from microbial, chemical health risks, And included in this is the critically important role that drinking water plays to support adequate hydration, support effective medication use, and recovery for all patients. Now, well-managed systems prevent Legionella growth, protect patients from respiratory infections and inhalations. Having safe and sufficient water for cleaning will strengthen infection prevention and reduce healthcare associated infections. Maintaining good water quality, disinfection, and safe reprocessing of all equipment. And finally, safe water enables high-risk services to be delivered safely and effectively. This would include hemodialysis, intensive care, and in particular burn treatments. And this can also help spread antimicrobial resistance. So next slide, please. Now, water in healthcare facilities must support all core functions, from drinking, hygiene to clinical care, cleaning, food preparation, and laundry. Okay, it must be available on site from an improved source and available at every point of care. And it must be safely treated, okay, reliable, and there being sufficient quantity, for at least 2 days of need. Next slide, please, Arabella. So achieving these minimum requirements demands reliable infrastructure, adequate capacity, sustained resources, strong management, continuous oversight, and all of these conditions that can often be weakest where health risks are the highest, particularly in emergency settings. Now, all of this underscores the importance and need for taking a risk-based approach. And what we mean by a risk-based approach is identifying and addressing the highest priority water safety concerns to achieve the greatest health benefit and protective value for the patients and staff, but also considering the resources that are available in a given context. Now, applying risk-based principles to safe water management and monitoring in healthcare settings can bring many, many benefits. So you can look at enhanced safety through proactive control of water-related hazards, can be a clearer understanding of the facility's water system, including risks from on-site sources, such as wells and boreholes, also the storage and internal distribution within a healthcare setting. There can be better use of limited resources by targeting actions where the risks are highest. There's faster detection and response to contamination events possible, supply disruptions and other emergencies, all of which can help to ensure more reliable and resilient systems. And lastly, but critically, particularly in my mind, it can really help ensure that steady, progressive improvement that's aligned with globally recognized best practices. So next slide, please. So applying risk-based principles in healthcare settings is not a new phenomenon by any stretch of the imagination. There's, of course, WASH-FIT, which you're all familiar with, and which is aligned with risk assessment and risk management principles, and also harmonized with the water safety planning approach. However, WASH-FIT is not intended to provide detailed guidance on the safe management of water supplies. And also, it does not, implementation in lower resource or emergency contexts can sometimes present challenges under certain circumstances. So if you could click, please. So based on this need and this gap, we have developed what we're referring to as a draft quick guide for safe water in healthcare facilities. Next slide, please. This guide is, excuse me, apologies there. So the quick guide, really in essence, it's a simplified approach to ensuring safe and adequate water in healthcare settings. Now, it embeds risk-based thinking and helps to facilitate strengthened operations and maintenance, management, monitoring aspects in relation to water systems. Now, where WASH-FIT is being applied, the quick guide can also support stepwise continuous improvement within the WASH-FIT framework. And the implementation of the guide can be supported using simple risk management and monitoring tools that are already available, including routine sanitary inspections. So next slide, please. I'm just going to give a very brief whistle-stop tour of the guide and how it can be used. And, in the first instance, users are encouraged to map their systems and better understand and identify vulnerabilities in relation to water quality and quantity. Secondly, next click, please. There is a strong emphasis on ongoing management activities. So basic operations and maintenance for key barriers within the system that prevent water being compromised, and also monitoring to ensure that these barriers continue to function effectively and within acceptable limits. So next click, please. And very lastly, then, an element of monitoring to verify that the water systems, quality and quantity and reliability, all of which is meeting required regulations and standards, and overall is effective in providing safe water. Now, if I can stretch your attention just with one last quick slide, and there is a lot going on here. I don't expect you to take it all in, but just to emphasize how the quick guide enables a stepwise progressive improvement approach in line with risk-based thinking. So in terms of what progressive improvement can look like in practice, the first steps can be simply conducting, visual monitoring checks and basic operations and maintenance in the absence of water quality testing capacity. And this then would go right through to the gold star approach at the top of the ladder that would encompass, say, visual and water quality testing measurements, routine operations and maintenance, and verification that the overall safety of the system, and doing this through, say, microbial and chemical testing where capacity is available, and ongoing sanitary inspection. So that's just to give you a flavor of this draft guide. I understand at the end of the session, we'll share a link, and we would be very happy for your feedback and further thoughts on how we can strengthen it. So with that, I'm very happy to hand back to Valentina. Thank you.
Thank you, Rory. Thank you very much for giving us a bit of a framing of what risk-based management is, and to show this quick guide in draft that is a nice complementing product to the WashFit water part, and can be introduced in ongoing WashFit implementation. I've seen Arabella has already shared the link to the quick guide if participants want to have a look. And I call now Alla Yushchuk from the technical officer at the WHO country office in Ukraine, who has supported a lot of projects on WashFit implementation and latest on complementary water safety in healthcare facilities. And she will present the past and ongoing work on water safety planning in WashFit in Ukraine. Thank you, Alla. The floor is yours. Alla, you need to unmute.
Thank you. Thank you very much. Greetings, colleagues. Thank you for giving this opportunity to share experience from our work in Ukraine on water safety in healthcare facilities. I would like to start with a brief overview on the use of WashFit tool in the country, as it has played an important role in identifying and addressing key challenges in the sector. The tool was first introduced in 2022 in selected regions in Western Ukraine. You can see these areas are marked in green on the map, and over the past 4 years, WashFit has been actively implemented under different initiatives covering more than 200 healthcare facilities, mainly in the frontline area. Some of the indicators have been adapted to align with national requirements to ensure the relevance to national regulation. And what I like to mention that in November 2022, Ukraine has also established the global HIRAMS platform, to assess whether healthcare facilities can maintain essential services during emergencies. And as part of this rollout, several WASH-related indicators based on WASH feed were expanded to provide a more clear and detailed picture of water and sanitation conditions. And this is currently actually the source of information for water supply. So the application of WASH feed in unstable environment demonstrated several advantages. First, it offered a structured way to rapidly assess the status of basic services and quickly identify gaps. Also, it strengthened coordination, allowing technical support and to be more targeted and efficient. This is why we see the active application of the tool in frontline areas. Also, it helped to with the provision of on-site mentoring and capacity building, which is especially critical in conflict setting. What's important to emphasize is that WASH feed was implemented along with the IPC framework, considering that IPC measures rely on consistent supply of high-quality water at every point of care, from hand hygiene, cleaning, disinfection, reprocessing medical equipment, and preventing waterborne outbreaks within the facilities. Also, healthcare water systems can be the source of pathogens such as Legionella and Pseudomonas. So, of course, high-risk clinical procedures require water that meets strict quality. And across the facilities, the water component of the WASH feed consistently received the lowest scores, and there are a number of reasons for that. First of all, the sector has long been weak. I mean, the healthcare facilities, many healthcare facilities in Ukraine are old buildings that with outdated infrastructure that require modernization, and water supply networks are unevenly distributed between rural and urban areas. In addition, there is a persistent gap in water quality monitoring. As a result, the system often end up in resolving problems rather than preventing them. Secondly, the war has created unprecedented challenges with direct and indirect impact on water supply services. Healthcare facilities are themselves under attack, and they had to adapt their settings to shelters, to move into temporary structures, to continue providing services. And this, of course, requires new water supply settings. Destruction of critical infrastructure also compounded this crisis, and a turning point in terms of water supply was the demolition of Kakhovka Dam in 2022, where that left several regions in southern part of Ukraine relied on bottled and transported water. Of course, healthcare facilities in this region struggled to secure safe water for drinking, hygiene, and medical procedures. So constant attacks also on energy infrastructure resulted in disruption of water supply within the entire country is another critical challenge. And what all this demonstrates how important is to develop autonomous facilities that keeps essential services including water and sanitation running under the crisis. So this level of autonomy has been made possible through several technical and infrastructure solutions. The governmental program and locals program supporting the construction of boreholes, in the territory of healthcare facilities, the installation of water storage systems. Many facilities have also to introduce on-site treatment units, allowing them to manage different types of water quality required for clinical and non-clinical purposes. And another critical tasks was to secure stable energy, and this has been achieved through the installation of backup power sources and active integration of alternative and renewable energy system, such as solar panels. So here we see how a sustainable solution contribute to resilience of healthcare facilities. So in terms of responsibilities for ensuring quality of water services and maintaining a technical condition, the water supply in healthcare facilities is provided by contractual on contractual basis and on the subject of licensing. And the water suppliers are responsible for maintaining technical conditions of external water supply networks, while healthcare facilities are responsible for maintaining its internal water pipeline system and equipment in proper technical and sanitary condition. So in the case of emergency, local authorities must have a rapid response plan and ensure that availability and backup water options, availability of backup water options. Well, when it comes to water quality, the critical situation in the region required some certain adjustments and that allow certain indicators to be reduced during emergencies, and as a result, under normal condition, drinking water quality must meet strict epidemiological, chemical, organoleptic criteria. But during the martial law, drinking water standards could be temporarily adjusted, where core epidemiological parameters remain mandatory, and while others allowed to follow less strict norms. On this slide, you can see the list of priority water quality parameters compared across the different frameworks, national, EU, as Ukraine is aligning its standards into EU legislation, and WHO recommendations. Now let's have a quick look on the situation in of water supply in Ukraine based on 2025 HIRAM's self-reporting data. Out of more than 10,000 healthcare facilities that are reporting into the system, 83 indicated that water was available, while remaining facilities with no or partial water supply were entirely primary healthcare centers. And this we see this pattern when looking at water storage facilities availability, water storage availability as well. So among the healthcare facilities most rely on pipe networks, boreholes as a primary main source. However, many still depend on secondary options such as wells or tunnel deliveries. So the application of WashFit helped to better understand the needs and weaknesses in water in healthcare facilities and water safety. I will not go through all of them for the sake of time, but among the main one are the following: the insufficient knowledge of estimated water needs for different purposes, drinking, technical, other purposes. There is no guidelines in national legislation, and facilities are using WHO recommendation. Second, many facilities they there is a lack of expertise to operate and maintain water storage system. Disinfectant water storage tank. Again, there is no clear guide in national legislation on this. Ensuring water quality remain a major challenge, as point of use testing and routine inspection is not applied consistently, and many facilities rely solely on the assumed safety of water they receive. But as I mentioned, at the same time, the situation has shifted, and a great number of healthcare facilities now drilled boreholes, their own boreholes, and now fully responsible for managing and monitoring their own water supply. So also many healthcare facilities has no reliable information on the actual quantity of water they consume. This is critical for installing treatment technologies. And finally, there is a need for internal policy documents such as SOPs, standardized procedures, and all this highlighted that the need for strengthening capacity of healthcare facilities to understand and manage water quality. This was the driver for developing the guide that was mentioned, and this guide was discussed with local stakeholders and with representatives from healthcare facilities, and both engineers, IPC staff, and the guide actually helps to document information on water supply, also ensure safety by conducting sanitary inspections of water sources, and using the results for planning priority action. So moving this, we are planning to engage regional centers for disease and control and prevention for providing methodological support, and also they can be a link between healthcare facilities and local authorities. Also, we are planning to implement the quick guide in selected healthcare facilities to support teams with regular monitoring, and also supporting national authorities in developing, strengthening national regulation on the issues I mentioned before. And to conclude, I would like to also list the benefits of from implementing these priorities, strengthening water safety and IPC system, directly reduce the burden of healthcare associated infections, including those caused by antimicrobial resistant pathogens. And this is particularly important as reports indicates the rise in RMR infections in Ukraine since the full-scale invasion. Also, it helps to reduce the outbreak of waterborne diseases in crisis settings. And at national level, this work strengthens resilience, sustainability, contributes to long-term modernization of water infrastructure, which is critical for recovery efforts. And finally, this approach moves the country closer to EU standards, particularly transition to risk-based model and more effective, efficient use of resources and healthcare facilities as most vulnerable settings is a good start for this. Thank you.
Thank you very much, Alla. I see that questions are coming in the chat and in the Q&A. We will get to those in a couple of minutes after listening to the next speaker. And I here we invite Dr. Zahid Mahmud, scientist and head of Laboratory of Environment and Health at the Division of Health System and Population Studies at icddr, leading International Health Research Institute in Dhaka, Bangladesh. Dr. Zahid will speak about water quality testing program in Bangladesh. The floor is yours.
Yeah, thank you very much. Yeah, I'm going to talk about comprehensive water quality assessment in district and national level hospitals across Bangladesh. Next slide, please. So the objective of this study was systematic sampling to map water quality transition from source to tap and guide hazard control and mitigation strategies in water safety planning. In this study, we collected water samples all over the country, about 180 hospitals. These 180 hospitals covered all the 64 districts, both secondary and tertiary level hospitals. We collected the source water sample. The source water is being tested for several parameters, and we found that all the source water is free from bacterial contamination because the source water is coming from underground aquifer. And after that, the source water is being reserved in most of the hospitals in the overhead tank, in some of the hospitals underground reservoir. And from those reservoirs, the water sample, water is being transported, is being traveled to all over the hospital. And we collected tap water sample from different high risk areas. And we collected water sample from labor room, high risk ward like SCANU, ICU, NICU, and operation theater. And the kind of bacteria that we tested are Escherichia coli, Legionella pneumophila, and Pseudomonas aeruginosa. All these bacteria are hospital nosocomial bacteria. Next slide, please. Let me show you the result. We collected tap water from 180 hospitals, about 538. And out of 538 tap water, about 48% tap water is free from bacterial E. coli contamination. But in about 52% water samples, water is contaminated with E. coli. And in about 0.74% tap water, E. coli contamination is more than 1,000 CFU per 100 ml. And also, that means E. coli in 100 to 1,000, about 11.5%. If we see the Pseudomonas aeruginosa, which is a nosocomial bacteria, and this bacteria, we found the presence of this bacteria is in about 82% samples. In some of the tap water, Pseudomonas aeruginosa concentration is more than 5,000 CFU per 100 milliliter water samples. If we see the Legionella pneumophila, in case of Legionella pneumophila, about 73.4% water sample was free from Legionella pneumophila, but about 27% samples, so we found the presence of Legionella pneumophila. Next slide, please. Next slide, please. Okay. Then the E. coli that we found, we wanted to see about their antimicrobial resistant pattern, because the water, the source water is free from contamination, but when it is traveling through the pipeline, it is becoming contaminated. And the E. coli that we found, we searched whether they are extended spectrum beta-lactamase producers or carbapenem resistant. Accordingly, we searched about 113 ESBL producing E. coli from 180 hospitals. That means 180 hospitals in 113 hospitals. Water samples was contaminated with ESBL producing E. coli, and about 38 hospital water samples are contaminated with carbapenem resistant E. coli. And then we tested according to CLSI guideline, the kind of antibiotics that that is used to just check the resistance pattern. And we found in some of the isolates, they are 100% resistance. And there is a possibility when the water is coming through the pipeline, the water is becoming contaminated. Bacteria has a tendency to form biofilm on the rough surface. And these bacteria most probably due to anthropogenic behavior, is forming biofilm on the spout of the tube of the tap, mouth of the tap. And on the other hand, there is aerator on the tap, and that aerator is one of the target for bacteria. And due to horizontal transfer, the bacteria is becoming resistant to different antibiotics. So here we can see that means some of the isolates are resistant to many antibiotics. And we also search the distribution of resistant genes among the isolates, and we have found that this kind of genes they are present on those isolates. Next slide, please. So this is the last slide because my time is very constant. And we also tested the heavy metal because in Bangladesh, out of 64 districts, 49 districts groundwater is contaminated with arsenic. And this is why we tested whether the source water is contaminated with arsenic or not. And we found that about 6% water sample, source water, arsenic level is more than WHO as well as Bangladesh guideline. According to WHO, arsenic is should be less than 10 microgram per liter, but according to Bangladesh standard, it should be 50 microgram per liter, and 6% samples exceeded the limit. And in case of iron, about 31% samples exceeded the guideline of iron concentration more than 1 milligram per liter. And in case of manganese, about 26% samples exceeded the guideline. So in brief, this is my presentation, and I'm ready. Just if you have any questions, I'll be able to answer. Thank you very much.
Thank you, Dr. Zahid. This brings us to the end of the presentation section, and I really thank all the speakers for your meaningful contribution. We have heard about a story of real resilience, but also inspiring for any country on what steps to take for improving water safety. And we've heard from Dr. Zahid such a large-scale exercise to improve water quality, and the clear links came across from all presentation with the infection prevention and control, but also the AMR control. So we will now go into the Q&A part, and we have received already some questions for our speakers. I've seen some have also been answered in the chat, but we'll go in order. So Dominic Andreas Kugler wrote in the Q&A a question about what rapid monitoring methods or field deployable systems are currently in use for detecting microbial contamination or general water safety risks. And this was asked in the context of Ukraine. Alla, would you want to respond?
Valentina, just
what rapid?
Can you please see the
it's about test methods. What rapid monitoring methods or field deployable systems are in use for detecting contamination or general water safety risks?
Rapid test methods, the chlorine residual, and it depends. I think Rory has answered on this question in the chart. We in healthcare facilities, they actually it's one of the main problem that testing is not applied consistently, but with the use of wash feed and working with healthcare facilities, we are supporting and encouraging them to use at least basic rapid testing available. with limited resources, but with the use of risk-based approach, and first identifying the risks and then performing comprehensive water testing. And with like in routine monitoring is the mandatory parameters is E. coli and chlorine residual.
Thank you, Alla. Roy, did you want to comment on other experiences?
Yeah, no, I think Alla has given a great perspective from Ukraine, and in my experience there, we visited not too long ago, and I think there really is quite limited capacity in many healthcare settings. I understand, regionally in other places, I mean, healthcare professionals are not, water quality experts or lab analysts, and a lot of facilities wouldn't even have the most basic kind of field test kit equipment. So I think it's really about understanding where the facility is on a ladder, and trying to progressively improve and have that view, to I guess understand that water quality, although it may come from a municipal supply or otherwise, where the water supplier is responsible, as soon as that water is on site at a healthcare facility, then effectively the healthcare facility becomes the water supply manager and is responsible for its safety. So I think, as Alla has mentioned, I think trying to encourage sort of the most basic quick field test kits if possible. But there was another linked question or comment in the separate chat about also, you have to recognize it's not possible or, essential to test water quality. It's great when it can be done, and it should be encouraged, but there's a lot that can be done in terms of basic visual ongoing checks. That is really the first step on the ladder to start improving water quality. So I'll leave it there. Thanks, Valentina.
Thank you. I believe that was the question about the role on, no, that was about test. Okay. Then we had Brian Reed that asked, given the variety in water quality needed for different uses, what is the role of point-of-use treatment systems in healthcare facilities? And he also asked about sanitary inspections that have been mentioned, and if these are for the water source using the standard WHO forms or other parts of the systems. I believe this goes to you, Rory, but happy for other speakers to complement.
Yeah, no problem at all. Starting with the sanitary inspections, they although they were originally developed for water supplies, we've been looking at adapting them and using them for healthcare settings. WashFit has long integrated sanitary inspection approach as a simple kind of rapid on-site field test to help identify risk factors. Then that management actions can be put in place to start improving the system and the facility. And so it's certainly not a new approach. But we, a number of the sanitary inspection packages are relevant for healthcare facilities. The illustrations might be a little off-putting because they're of water supplies, but when you look at the questions, so many of them are still applicable. A lot of healthcare facilities around the world would have their own on-site water sources that might supplement municipal supply or be the only supply. So the sanitary inspections for water sources such as boreholes, wells, springs even, and then many facilities have on-site storage tanks. They would have communal taps or individual taps. So there's still a lot of the sanitary inspection questions that would be relevant in healthcare facilities. To the second part of Brian's question, I won't pretend to be an expert at all. Someone may prefer to step in. Brian's hit what was a key not issue, but key thing to really get our heads around is there are so many different uses for water in hospitals. There's obviously drinking water. There's water for preparing medications. There's water for cleaning, disinfection, laundry. So many different purposes, and some require different technical grades, which may require hospitals to have different. There is a role for point of use in the traditional sense that I would understand being almost kind of bedside treatment of water, or communal dispensers or filters at taps. But then there might also need to be further on-site treatment to bring municipal water up to medical technical grade for certain, for ICU and for operations. But again, I'm by no means an expert there, and if anyone else would like to complement that, I would be most grateful.
Thank you very much, Rory. I see that many questions are also being answered in writing. So we'll move on with, I think I will give a break to Alla and Rory and go with a question for Dr. Zahid. Thank you for the wonderful presentation. Did you make any distribution map of the microbial contamination based on the locations of the tap?
Yeah.
And for sorry, there's a follow-up question. And for the heavy metals, did you notice any geographic significance?
Yes.
Like,
thank you very much. Yeah, thank you very much. We have just completed the project. We are analyzing the samples. And in case of heavy metals, yes, in some areas in Bangladesh, there are some areas where there are arsenic contamination. In those areas, we are getting higher arsenic in those areas. But in case of iron, almost all over the country, we are getting iron contamination. That means the iron level is higher. Because this heavy metal is present, all over the country. But arsenic, there are some specific region where their arsenic concentration is high. And now manganese is also coming forward. Previously, we didn't see that much of manganese contamination. But in our study, we found about 16% water samples were contaminated with manganese. Over to you.
Thank you very much. I think this replied very well. So we move then with a question from Maggie Montgomery about what operational monitoring measures can be done when water quality monitoring equipment is not available. I think, Rory, you replied partially before already to this. Do you want to add anything?
Yeah, I just gave a quick answer there. I don't have a huge amount to add other than just to emphasize that, don't let the absence of water quality testing equipment be a barrier to improving, safe water management. We mentioned already, the visual checks that can be done as a starting point. And it's it's well recognized that healthcare facilities, not all of them will have the resources or capacity or staff to be able to do extensive on-site testing. So yeah, I just can't emphasize that point enough. So that's all I want to add. So somebody else may wish to add to it.
Yes, I can also add that you can also visually check the infrastructure and the taps if there's any leakage that may lead them to later contamination. So there are also other parts beside the water itself that may need to be considered in the monitoring practices of the healthcare facilities. Alla, you wanted to add anything?
Basically, no. I think we covered this in the first and the second question. So the only thing is, as I mentioned, the engagement of centers for disease control and prevention, as they can be more capable to conduct the analysis and also to go to the facilities and support them, especially in those areas, settings where there is lack of expertise and staff, and support them with conducting this risk assessments, identifying risk, and basically performing the analysis. This is why in WHO we are also helping their laboratory to strengthen their laboratory capacities so that they can cooperate with healthcare facilities directly, but mainly on identified risk, not on the full checking and screening and for a risk-based approach and efficient use of available resources.
Thank you, Alla. This fits nicely with another question about the role of regional CDCs in Ukraine, but also how other countries and implementers can work with the local public health authorities to support the water safety. So you mentioned the laboratories and the capacity building. Is there any other role that they may play to support with capacity?
Yes, they play a very important role because they serve as a link between local authorities and healthcare facilities, as they can provide guidelines and methodological support directly to healthcare facilities, but also technical consultation to local authorities to help them prioritize needs and identify potential gaps also on a national level that will at the end result in changing the policy, probably local regulation or national policies. So their role is critical. And in Ukraine, we are trying to strengthen their capacity because they can be very useful in performing this risk-based approach and supporting healthcare facilities by guiding them and also providing the mentoring support. And on the other side, consulting and helping the local authorities to identify priorities and actions for improving.
Thank you. That was a comprehensive reply. We will move to the next question. We go back to the technical side from Bruno Pasquale. Chlorination and the capacity building required for correct dosing in healthcare facilities remain major operational challenges. Could you share any practical tools or guidance materials that support field teams in calculating the appropriate chlorine dosage for drinking water treatment, surface disinfection, and sterilization across different chlorine concentrations? But I guess this could also be answered in writing, but if anyone has a quick reply to this. I'm sure it's a yes.
Happy to to jump in. Yes, it is a big challenge in the field. There are a number of tools out there. I'll maybe share them in the chat after this, some that were developed for other regions for water suppliers, but they include the basics of chlorination and some what we call cheat sheets for calculating dosages. And there are some resources from other partners as well. So I can share all of those in the chat in a few moments.
Thank you very much. So another question for Dr. Zahid from John Brogan. Dr. Zahid, you mentioned the biofilm found on the mouth of taps in healthcare facilities where your study found the antimicrobial resistant strains of bacteria. Have any recommendations been made or actions being taken for managing risk of particular hotspots like the taps you found?
Yeah, thank you very much. Actually, we are thinking that it might be due to biofilm formation. We did another study in the Rohingya refugee camp. That means, in Bangladesh, there are Rohingya populations are living, and over there are about 5,000 tube wells. And we did one study under UNICEF finding that we collected water sample from the tube well mouth, and after that we decontaminated the mouth of the tube well, that means spout of the tube well, and then we parsed the tube well and again collected another sample. and we found significant difference. That means the water that we collected without any decontamination, we found E. coli contamination over there. And after decontaminating the spout of the tube oil, when we collected another batch of sample, we didn't see any contamination. And the E. coli that we found on the spout of the tube oil, and we did the genetic analysis, antimicrobial resistant pattern, and we found that they are resistant to different antibiotics. And we found that due to anthropogenic behavior, the tube oil mouth is becoming contaminated. In Bangladesh, or in Rohingya camp, after just coming from the latrine, they are rubbing their hands on the tube oil mouth. Before going to the latrine, they're putting the pot on the tube oil mouth, and different ways the tube oil mouth is coming in contact with just dirty hand. And the bacteria is coming in contact on the rough surface of the tube oil mouth, and they are forming biofilm. As you know, Bangladesh is situated in the tropical region. During summer, our temperature is more than 30 and very conducive temperature for the proliferation of bacteria. And this enhances bacterial proliferation and biofilm formation. Thank you. Over to you.
Thank you very much. So it's good to consider also the context to understand all environmental aspects, to understand what measures to take. We have then a question, an interesting question from Seth Gia. Healthcare facilities in Ghana do not know the state of their water quality before usage. And what can be done to change this phenomena? What can we do to change the fact that healthcare facilities don't know the state of their water quality? That's a more meta level question. I think, Alla, you were replying a bit to this before when you were talking about the CDC role.
This is the same situation, that the challenge that we face in Ukraine, but the application of WashFit helped them to think about that and why this is important. It's like raising their awareness and being more active. Also, the role of CDC, exactly, as their function is to identify risk, and regular monitoring is the one of the part of it. As in Ukraine, we are aiming to work to, we developed this quick guide, which is a very simple tool. And this tool helps to structurize information. And we are planning to apply this tool, which is very simple and easy, and support healthcare facilities. And this tool will also help them to understand why it is important, as they will have to fill all the forms in this guide, and this also like providing them certain structurized information and explaining that it's not difficult. It's there is a lot of much more benefits from routine monitoring and inspection than responding afterwards. So this is also like a simply approach, a simple and easy approach to the healthcare facilities is also can be useful to start building the routine monitoring system.
Thank you, Alla. There's also, I think we need to wrap up. We have on the screen the QR codes to the resources that have been mentioned. There was another interesting question. I don't know if you can, if some of you can answer in a 15 seconds answer, a quick fire. These initiatives are great, but often are project driven and fragmented. What is the incentive to follow the safety measure as a standard practice on the long term for healthcare facilities? Can we identify incentives for places where the safety measures are being followed properly? Any very quick answer?
maybe I can again. I will repeat about engaging CDCs because it helps to maintain sustainability. When it's a project, it starts, its end. But if it's CDCs, it's an it's their role and integrating all this function into training them, providing materials, methodological materials for those structures will help to have this sustainability of the results. And about the examples, not yet. I think we will have them.
Yes, it's still learning in progress. Thank you very much. I would like to thank all of you for your great contributions and to all participants for the very nice questions. It was a learning experience also for me. So we have heard that safe water is really a major aspect and it can be even expanded under the WashFit work. It underpins quality of care, infection prevention and control, and AMR. I appreciate how these topics came throughout the entire conversation. And unfortunately, these cross-linkage are often also neglected inside healthcare facilities. So we heard how important is the risk-based approach, and all of us that have been working with WashFit has already knowledge about this. And I would like to encourage all of you to have a look at the quick guide and send us any feedback you have or any result of testing. We have learned that we're not only in the technical work, but we need governance and engagement of multiple stakeholders. And also in this field, data matters. We've seen with the example of Bangladesh, we need information and also with Ukraine that can shape our actions. So I hope you found this event relevant. Thank you for attending the first WashFit meetup of 2026, and we look forward to seeing you at the next appointment in May, which I remind you will focus on safe plumbing. Please share your country experiences and challenges so that we can strengthen our peer learning group and reach out to you with your suggestion on additional themes that we should cover in the future WashFit meetups. Thank you, everyone, once more for participating, and see you next time.
Yeah, thank you. Thank you very much.
Thank you.
Thank you. Bye-bye.